So hi everybody, I'm Francois. I'm a professor of medicine at the University of Witwatersrand in Johannesburg in South Africa. They've asked me to chat about COVID in Africa, and as everybody involved in COVID will tell you, we weren't doing this 7 months ago, and we're all newfound experts in the area. My actual field of expertise is in HIV, and I'll be talking a little bit about HIV as we're going along. But I think it's important to talk about the fact that the African epidemic in terms of the rest of the world is probably the one which we know the least about. And I'm going to try and explain some of the data we do have, which is very limited, as well as just some of the responses that have been seen across the continent. So I think the first thing to talk about is just to emphasize that Africa is a very, very big place. You know, even South Africa is a very big place. You can take Spain and France and Germany and Italy, and you know, they could easily fit within South Africa's borders alone. So there's, you know, when you look across at how these vast tracts of land, plonking everybody into one massive bucket, it just doesn't really work. And even within the countries, you know, there's huge differences in terms of what you see, and it has huge and profound implications in terms of coronavirus control. So this very famous photograph demonstrates this. This is a sort of obviously helicopter type view of an area around Cape Town. And on the left-hand side, you can see incredible dense population of very poor people. On the right side, you can see some of the richest people in Africa, separated by possibly 150 meters. So, you know, it's not just within the countries and within the continent, but even within local communities, there's incredible disparity and incredible disparities in wealth. And with it comes, you know, somebody on the right in those rich communities is going to find physical distancing probably very easy, and he's going to have access to some of the best medical care in the world, while the people on the left, you know, physical distancing is going to be tremendously difficult, while and creates all sorts of issues around simple things such as hand washing, where sustainable water supply is not necessarily there. So in the area I work in here in Johannesburg is on the far left is this deep urban side. Up at the top right is a informal settlement, and near one of the trains running between the cities. And then on the middle you can see a completely different way of living out on the wild coast of South Africa. So this is just in South Africa. You can see these incredibly different and varied places people live. So, but there are some things African countries share, and they share it with many of the poorer countries in the world, in South America, in Asia, and other places, Central America. The first thing is that we have severe resource limitations. Even resource-rich countries, relatively, such as Botswana, South Africa, and Namibia, have health constraints. We have a limited number of beds, hospital beds, ICUs. We have limited access to PCR technologies. And also within the central cities, we've seen in many parts of the world that's been very overcrowded, densely populated areas like New York and the cities of Europe, and now increasingly in Brazil, where the virus finds it very quick and easy to tear through these places. And certainly in Africa, we have many super cities which are very densely populated. And certainly in South Africa, which I'm going to get into a moment, that's where we've seen the biggest hit. We also have limited communication networks, as well as access to the technologies that many of the other countries, such as used in Asia, around using cell phone tracking to try and try and monitor people. And sometimes it's not that the communication networks don't exist, it's the fact that tracking individuals, the individuals are very poorly characterized in terms of knowing who they are, who owns this cell phone, who has access to that technology. So I'm going to list some of the things that I think there was a lot of hope around what would save Africa, what would protect us from the ravages of the coronavirus, what could perhaps be looked to that would be something we could take some hope in. If we have this severe resource limitation, that we do not have infinite number of ICU beds, that ventilators are in short supply, and that things such as physical distancing are going to be very hard in certain communities. So what did we hope? And the first thing was a lack of transport networks into the continent. And HIV has some lessons here for us, which is that in some ways I feel like coronavirus has behaved very similar to HIV. You know, it's kind of an accelerated way. And it's important to remind ourselves that actually the origins of HIV were here in and around Kinshasa in around the 1880s, 1890s. And this has been very well characterized. And in fact, didn't spread very far at all. It stayed contained in a very localized area. It actually reminds me quite a lot of the initial SARS epidemiology, where it went out and then kind of contained. But HIV then, over the space of decades, had very different forms of spread. The initial spread was probably an iatrogenic spread across Central Africa, propagated by the syphilis and trypanosomiasis programs. And then spread into, with the rise of air travel, then started to spread into Europe and into the United States. Again, which is the case with SARS-CoV-2. But different modes of spread in different ways, where in the spread of HIV to Southern Africa was very much a heterosexual spread, and which was partly to do with the public transport networks. So when we were looking at public transport networks, they certainly propagated the HIV virus across the continent, and has led to a very disparate group of infection rates across the continent, where some places in Africa have actually incredibly low HIV rates, while others have got the highest in the world. So what we see here is that certainly in Africa is certainly far less air travel than almost all the rest of the world, when you compare to a place like the United States and Europe, where huge numbers, where air volumes are very high, and it's very localized around certain major transport hubs. Public transport, in terms of road transport, in terms of train transport, is also very constrained. And we wondered whether this protected us. I certainly believe that the delayed spread into Africa, we were the last ones to have really flaring epidemics, probably was a result of these limited transport networks, and that the seeding of the virus just took so much longer than it did in a place like Europe or America. So what else could say of Africa? Well, race. People have thought perhaps something about being African origin, perhaps there was some genetics. We know that there's race-based stuff in terms of transmission, in terms of getting of the virus, in terms of certainly with HIV and other viruses. Could perhaps being black be protective against the virus? And sadly, I think that what we're seeing, and it's difficult to unpack this because race is so intertwined with social factors, but being black certainly in America is not protective, and certainly being brown is not protective either. So having Asian descent doesn't help you, because we've seen certainly with good data from the United Kingdom that the people from Pakistan, from India, from Asia seem to have had a greater mortality rate. So this is not reassuring. And although we don't have good data yet in terms of race, obviously within Africa, we haven't got the epidemic firmly yet. I don't think there's enough to go here and saying this is what's going to save us. So the next thing people thought, well, Africa, particularly Southern Africa, has got this HIV epidemic. One of the drugs which is used in possibly 99% of patients is a drug called tenofovir. Now, this drug has got some corona activity, and one of the thinkings around it, and there are actually studies looking at whether it can stop you getting COVID, giving it to healthcare workers. There's a large study being undertaken in Spain. The idea was maybe our HIV patients won't get it. And in a place like South Africa, where as many as 15% of the population are on tenofovir, it would be a wonderful happenstance. But the problem is here with this data set, which was just in the last 2 weeks being made available from the Western Cape, which has got this huge onset of COVID cases, they actually demonstrated that, in fact, HIV patients, most of whom are on tenofovir, and most of whom are actually taking antiretrovirals, firstly, there was no difference between whether they were on tenofovir or they weren't in terms of mortality, but also compared to the general population, there was a twofold increase in terms of mortality. So while the mortality increase wasn't what we see with diabetes or we see with age, it certainly was not nothing. And this is one of the best characterized data sets that has come out. There are other studies from Europe, for instance, that might suggest that there may be some protective effect with tenofovir, but I don't think that, hand on heart, we can look at this data and be reassured that our HIV epidemics can provide some sort of paradoxical benefit to us in terms of protecting us from the ravages of coronavirus. And just another thing on one of the paradoxes of the HIV world is that one of the drugs we are rolling out across Africa and across the world, in fact, is this class of integrase inhibitors. And dolutegravir, which is the one which has now just been recommended in the last year as first-line therapy, and where tens of millions of Africans are busy transitioning across, has been promoted and is being given to, as I said, practically everyone in Africa at the moment. So we see the major side effect of this class of new drugs, of the integrase inhibitors, is weight gain. And this is one of the major studies undertaken here in Johannesburg of a large population of people from across Africa, which demonstrates that the middle bar in blue is what most Africans are now on. A steady increase in weight, particularly seen in women over time. And as you probably well know, is that obesity is one of the issues associated, one of the factors associated with severe COVID disease and mortality. So we have this paradox where we might be making everyone fat on the antiretrovirals and leaving them open to the ravages of COVID. And this is not a good thing, because we don't have good alternatives to this drug. The reason we went to this drug is because of its excellent tolerability. This was an unexpected side effect that's been only characterized in the last 18 months. So what else could save Africa? Well, we were all hoping our climate. I'm not quite sure why people thought climate, but it seemed to be a cure-all for lots of things, because Africa has an incredibly diverse climate. You have the Lesotho where there's snow and you can actually ski, all the way up to Mali, which is deserts and is completely different. So having said that, I think that there's been a fair amount of work on climate mitigation and looking at whether it has any impact. And most of the modeling I've seen have said at most it has a very moderate effect on the spread of COVID. So again, for us in Africa, this is not something that is necessarily reassuring. One of the things we are going to have to deal with in Africa is this idea of the surges. And I guess it's something for the whole world, but for us, is this going to happen every winter? Is it going to happen in autumn and the fall? Is it going to, autumn and spring? How are these pandemic valleys going to look going into the future? And one of the things we are concerned about is have our various lockdowns just simply delayed the initial peak, and what will the second peaks look like? Or will there be any second peak at all? The next thing we're hoping will save us is our demographics. Like, is it because Africa's so young that they're therefore going to be spared all of this? And also because we're so young that we don't have all these non-communicable diseases which are implicated in the morbidity and mortality of COVID, including obesity, including diabetes and hypertension. And it's important that age does appear to be a factor, and I've got some data to show you in a moment, but most African countries actually do have a relatively young population. It's the nature of these populations. Now, except there are some notable exceptions, and South Africa actually is one of them. People keep telling me about how South Africans are so young relative to the rest of the world. And there's actually only a 2-year disparity in terms of South Africa's age and the average age of the world. So it's not that South Africa is that much younger than everybody else, but certainly other countries have got a younger group of people, and certainly the Americas and Europe and even Asia. So it's important when you look at this to understand that also within Africa, certainly South Africa and probably some of our richer neighbors, that non-communicable diseases are actually a major issue. In South Africa, diabetes is the second biggest cause of death now that HIV treatment programs are so ubiquitous. And we have a significant burden of disease from hypertension, from cardiovascular disease, from kidney disease. So simply saying, oh, we don't have this burden, it may be so for many of certainly the very poorest countries, that their burden of non-communicable disease is less so than compared to TB and to malaria. But it's wishful thinking to think the entire continent is spared from this. And certainly, again, coming back to Marianne Davies' Cape Town data or Western Cape data, you can see that South Africa had exactly the same demographics and risk factors that you've seen in Europe and you've seen in North America and everywhere else, and in Asia, that the older you are, the greater your risk, the more likely, if you have diabetes, particularly in her data set, I haven't shown the data here, if you have uncontrolled diabetes, if you have hypertension, if you have other chronic disease, and even if you have TB, that there is a significant increase in your risk of severe coronavirus and death. So what happened with these initial responses? And as I said, all these things we were hoping to save us, well, what have we seen? Well, it does appear that the severe travel restrictions that were imposed across the globe, but particularly in Africa, many African countries shut down their airports quite quickly, actually, very much focused on flights, although in places like South Africa, they also shut down many of the other transport networks. And borders were generally closed very quickly. So there certainly was very slow intercontinental spread and slowed in between the countries, people with the border closures and everything. And certainly in South Africa, where people weren't allowed to be on the streets and they weren't allowed to drive, except for in very restricted areas within a few kilometers of where they lived, that probably did have an impact. Many countries also imposed stringent lockdowns. South Africa, one of the most stringent, where people were underwent various versions of curfews in terms of what they could buy, what they couldn't buy. I'll talk about the South African one in more detail, but every country seems to have had some form of lockdown, and many of them have been very, very severe. The continent as a whole has had very limited PCR testing. There's a few exceptions, again, Botswana, Namibia, South Africa, because of their very sophisticated HIV programs, actually had relatively sophisticated PCR testing. But even in those countries, the access to the reagents initially was very limited because the whole world was competing for these PCR tests. And within South Africa, it's become a perennial rolling shortage where the machines are there, but the reagents to run the COVID tests on have been very limited. Other countries have been far less successful in terms of sourcing it. So, and with that comes a very limited understanding as to what's actually happening in those countries. At the same time, we've seen across, as you've seen in many other parts of the world, including South America and in North America, issues around human rights. And as the police and the army have been deployed, politicians have used this crisis to tackle whatever, or whichever political party, political figures. And we've seen lots of human rights issues arising, including in South Africa. With it has also been the usual, something we've also seen across the world, not just in Africa, but where Trump was going on about chloroquine in the absence of any evidence, and other sort of Western politicians. We've had our own African presidents standing up and saying they've got whatever snake oil they're punting as a cure. So I'm going to talk very briefly about South Africa because that's where I live and there's probably the most data in terms of Africa. Just remember that South Africa is a middle income country and it has, as I said earlier, it's got good coverage with its laboratory infrastructure. It also has, paradoxically, one of the countries with the most pandemic experience. A lot of our doctors and nurses were deployed into the Ebola epidemic, even though we only saw a handful of cases both in the 90s and recently. But we have an MDR TB epidemic, we have an HIV epidemic, we've had a massive listeria outbreak in the last 2 years, we've had cholera. The country has a lot of experience and a lot of expertise, and a lot of people based in government institutions who know how to deal with pandemics. And as of this week, South Africa has the 10th most cases of COVID globally. It's way behind America and Brazil and Russia, but we're certainly up there and by far and away the earliest case. As I said, because the rest of the continent has often limited access to PCR, it's very difficult to understand if that's accurate. But certainly we're burning in terms of the number of cases, and it's sweeping its way across the country. In early March, the country undertook one of the world's most excessive lockdowns, I would argue, in retrospect, but severe. We had the army on the streets, people were under curfew, severe limitations, people weren't allowed to buy alcohol, cigarettes, they weren't allowed to buy certain kinds of clothing, almost anything. You couldn't buy cars, furniture, you could buy food, you couldn't go out, you couldn't play sports, you were told to stay home, you couldn't even jog on the streets. So, and there was complete shutdown of the economy for a period of 5 weeks, which was steadily relaxed in small states since then, and is still severely constrained. It's also had a massive impact on primary care with all the other programs, HIV, TB, vaccines, diabetes, non-communicable disease treatment programs, screening, have all been compromised. The Western Cape was hit the hardest and initially, and has still been gutted by the virus. And it seems to have peaked, we hope, but has been, you'll see in the numbers in just a moment. But what's happened then is it swept away to the adjoining province, the Eastern Cape, which is a much poorer province, triggering the near collapse of many of the hospitals actually in that province. So just simply, that province's hospitals are already severely constrained. Just a slight kick with an increased patient load has almost collapsed those services. And now my own province here around Johannesburg has seen a dramatic increase in number of cases in the last 2 to 3 weeks, and a fairly dramatic increase in number of deaths, with lots and lots of healthcare challenges. It doesn't have the infrastructure that the Western Cape has, although it is better off than the Eastern Cape. And what we've seen in the last 3 days is 3 of our 9 provincial heads have been infected with COVID. and all of them have self-isolated. They've all been symptomatic. But also with this, entire bands of politicians have been infected, and high-profile people across the country. And I'll show you the raw numbers at the moment, so it's not surprising. But what you're seeing happening in Europe and America, you're seeing here. And these are the stats. I'm not sure when this is going to be broadcast, but this is as you can see, as of the 9th of July, yesterday. South Africa actually has really quite well collected stats. I would be a little bit reticent about the testing numbers, but we have the absolute number of tests is over 2 million. We've got, as you can see, almost 250,000 positive cases, and our death rate has soared with almost 4,000 people dying of the virus. And these are confirmed, really, we're pretty certain of confirmed cases. How many silent deaths there are is a little bit difficult for us to presume at the moment. Death data in South Africa is actually collected pretty well relative to many places in the world. So this is probably it's probably undercounted, but not massively undercounted. And here you can see, just if you go off to the right, the absolute numbers, but you can see here on the right, which is the Western Cape, which is a province of about 7 million people. They were the epicenter for the last 2 or 3 months, but rapidly the Eastern Cape has caught up, and now my province, which is about almost twice the size of the Western Cape, is rapidly catching up. As of yesterday, we had the same number of deaths per day as they did, and we'll probably the data tonight will demonstrate that we're starting to rapidly outstrip the Western Cape. And these just shows you the incredible provincial disparity in terms of the reported number of deaths. And if you go off to the left, you can go to the bottom where you can see our total number of deaths. You can see how the Western Cape has totally been swept away. The Eastern Cape at the top there is coming a close second and still burning its way through that province. But my province, Gauteng, is now rapidly catching up. And we're seeing this expanding across as we go along. So again, to my eye, with all the limitations of looking at this data, we are starting to behave exactly in the same way as we see in Europe and in America. What's happened, this is a paper we published 2 weeks ago, is a dramatic impact on the other disease services. So here you can see that the TB testing rates, level 5 was our severe lockdown, level 4 was the slight easing, but you can see the testing rates for tuberculosis, how dramatically that has come down. We've seen the same thing with viral load testing, with HIV testing, with vaccines. And what this tells me is that the next 6 months to a year, at least, we're going to be cleaning up the mess that is, unfortunately, this huge impact on primary healthcare services. So it's not just coronavirus we're dealing with, but a wave of mortality and morbidity associated with these other diseases. So my last slide is now the so what of it, and what can Africa anticipate? And I think there's so many unknowns here still, and in many ways we have so many more unknowns than, say, America and Europe, where at least there's some pattern across the continents that we can start putting into something. I've talked about South Africa. It's very unclear that whether or not South Africa mirrors the rest of the continent. We're a much richer country. We've probably got more, much more infrastructure in terms of public transport and stuff. Although we did lock down very, very intensely and very severely, and there's a lot of debate as to whether that actually what kind of impact that had. My instinct is it's delayed things, but what we're seeing at the moment is eventually this thing is going to filter out and is going to take its toll across cities in particular. And as I said, all those things we were hoping against hope were going to protect us have not protected us. If South Africa has anything to go by, all the factors that are associated there are associated with death and mortality and severe diseases there. The one mitigating factor is, of course, age, and that seems to be fairly consistent across the board. Is that the South African data looks exactly the same as the data from Europe and America and Asia, where the older you are, the greater your risk. And I guess the question is, are we going to be spared, or has it just been delayed? Are we going to just have one massive peak and it's going to peter out and disappear? Or are we going to have multiple peaks? Or, the rural provinces in South Africa, for instance, are not seeing these numbers yet. Are they protected because just physical distancing is easier in the rurals? Who knows? But there's, we're just desperately looking for more data. And it's difficult looking at Asia, where these incredibly sophisticated lockdowns have happened. to Europe, where it's a very old population and where the demographics of spread have often been quite complex, or to America, which is just a chaotic mess. And watching what's happening in South America at the moment is very, very scary, because I don't think there's any guarantees at this stage about what we can expect as Africans. So I think the final point is that we're looking at a globe where there's a lot of selfish nationalism. We've seen the rise of particularly in the USA, of taking drugs and saying we're going to be using them for our local populations. We've seen PCR testing being deployed within certain countries and stopped in terms of transport to other countries. We've seen both India and China stop drug transport to other countries, when it's been looked as if these drugs could be purposed for the local populations. I think we've seen incredible solidarity from scientists and medical people, and incredible generosity. Certainly, I can say as a South African, we've dealt with the Russians, with the Chinese, with the Argentinians, with the Brazilians. And I think that in many ways that is something to look to as to feel good about. But I do worry that if a vaccine comes, everybody's going to be looking for it, in the same way as everybody's been looking to PCR testing. And I'm really worried that, you know, in terms of Africa, we do not have the manufacturing capacity at the moment to make billions of vaccines for our populations. And if we are going to be at the back of the queue and have to deal with an epidemic that's severe, that in many ways we're going to be the worst affected in the entire globe. I hope I'm wrong, and I hope that's nothing as bleak as I've portrayed, but there's a lot to be scared about at this point, because we really are lacking basic data across the continent. Thank you very much.